Transplantation, the science of moving tissues or organs from one side to another, often between different individuals, was undoubtedly one of the greatest medical achievements of the last century. It allowed defective organs or tissues to be substituted and provided an alternative for the treatment of many fatal diseases. However, the same limitations that prevented its implementation before modern immunology have never truly stopped hindering it. This is a video on mechanisms of graft rejection. You see, historically during evolution, say for pregnancy perhaps, organisms did not evolve to harbor tissues of different genetic code. Until very recently in human history, having cells with a unique genome inside you meant either you were infected by some pathogen or parasite, or had cancer. And in either way, attacking the foreign cells was mostly the best choice. For sure, there are symbiotic relationships, such as with our gut flora, but it's not technically truly inside us, just in our lumen. Let that flora reach our bloodstream and we'll test how symbiotic they truly are. It's only extremely recently we began adding tissues or organs that perform necessary or beneficial functions to our bodies, and they haven't changed thousands of years of evolution in 7 decades. Thus, while immune cells will attack pretty much any different cell, the host immune cells will attack the graft, and the graft immune cells will attack the host when possible. This is true whether we're talking about fluids, such as blood, or solid organs, such as the liver. There will always be some degree of aggression between graft and host. Since our blood is full of immunoglobulins and lymphocytes, and the graft has to be perfused, aka receive blood, to survive, immune cells and proteins will inevitably reach the transplanted organ or tissue. Rejection is merely the term used for when the damage from such aggression is enough to render the transplant ineffective. To try to avoid this, we always immunosuppress the recipient or host to hinder him/her from mounting a defense against the non-autograft. That means, in simple terms, we strive to make the host immune response system weaker so it fails in attacking the graft. There is little that can be done against preformed antibodies, however, which is why we need donor and recipient to be compatible. If the recipient is already sensitized to the donor antigens, no amount of immunosuppression is going to change the fact he already has circulating antibodies in his blood that will attack the graft voraciously as soon as it's placed. There are 4 main mechanisms of rejection: hyperacute, acute, and chronic rejection for when the host damages the graft, and graft-versus-host disease for when the graft damages host tissues. Naturally, the difference in speed is a consequence of different mechanisms. Hyperacute rejection, as the name implies, is the fastest of all, often within minutes, because it's based on the presence of preformed antibodies in the host. Either there was blood type ABO incompatibility between donor and host, or the host was already sensitized to the surface antigens on donor cells, the HLA-MHC complex. These preformed antibodies will immediately bind to the graft's endothelium as soon as it's supplied with blood, activating complement and causing massive damage and inflammation in the graft's vessels. The vessels will thrombose and lead to ischemic necrosis of the graft. It happens virtually immediately, starting often minutes after organ supply. While very cinematic and great to describe in questions with rapid thrombosis and darkening or paling of the organ within minutes, denoting necrosis of the graft, it fortunately is rare today, since we test donor-recipient compatibility. This is, however, what would most likely happen if you transplanted any organ from a random person into someone else without checking for compatibility first. Besides, not all organs are created equal. The kidney is far more susceptible to hyperacute rejection than the liver, for example. Acute graft rejection is analogous to primary immune response. When encountering the graft cells MHC, your naive B and T lymphocytes will become sensitized in the same way you would mount your first immune response against any antigen you've never been exposed to. Thus, if immunosuppressive drugs fail to inhibit your immune system, within days or a few weeks, it will start sending TCD8 cytotoxic cells, activating macrophages locally, and producing antibodies against graft antigens. Since the endothelium is the most easily reached part of the graft by the antibodies and cytotoxic cells, essentially the interface between the host and the graft, vasculitis will be observed, with large amounts of mononuclear cells in the interstitium. So, just as hyperacute rejection is classically associated with mismatched donor and recipient, acute rejection is the rejection type most associated with immunosuppressive failure. Finally, amongst the host versus graft phenomena, after many months or years, the patient can develop chronic rejection, marked by progressive occlusion of the graft blood vessels due to proliferation of smooth muscle cells in the intima mediated by T cells. Proliferation of fibroblasts may also be induced, leading to graft fibrosis. This could mean, for example, accelerated coronary atherosclerosis in transplanted hearts, bronchiolitis obliterans in transplanted lungs, vanishing bile duct syndrome in transplanted livers, or glomerulopathy in transplanted kidneys. Why this happens is not well understood. It's postulated type 2 and 4 hypersensitivity are seen, and that could be linked to sensitization to minor histocompatibility complexes present in the graft, particularly on the endothelium, leading to chronic inflammation-induced arteriolar remodeling. Theories include cross-reactivity after viral infection, interaction between direct and indirect rejection mechanisms, and complication of multiple previous acute rejection episodes, to cite a few. Treatment is, therefore, not well established either. And then we have the odd one here, the graft-versus-host disease, when the graft lymphocytes recognize antigens in the host tissues and start mounting a defense against them. Now, almost any graft may harbor some circulating lymphocytes when transplanted, but for them to be in significant number, we are most likely talking about the bone marrow, a blood transfusion, or the liver, particularly the bone marrow. When the bone marrow is transplanted, some of its lymphocytes might recognize antigens in the host. After all, in its previous body, those were foreign antigens. Now, however, they will attack basically any cell from the host that displays host antigens, that is, pretty much all of them. Thus, it usually manifests with systemic findings such as hepatosplenomegaly, jaundice due to bile duct necrosis, diarrhea due to gastrointestinal mucosal ulceration, and generalized maculopapular rash. So, to recap, we have 4 mechanisms of graft rejection. 3 of them are the recipient attacking the graft, whereas graft-versus-host disease is the graft attacking the host. In the 3 types where the host is attacking the graft, we have hyperacute rejection within minutes caused by preformed antibodies against ABO or HLA, causing thrombosis of the vessels that can be averted by checking for compatibility first. Acute rejection within weeks or months, caused by a primary immune response against the donor antigens, causing vasculitis that can be prevented with immunosuppression, and chronic rejection after years, debatable cause of intimal muscle proliferation and widespread fibrosis with no established treatment. And if you are interested in better understanding which hypersensitive reactions are involved with each of these, I will link my hypersensitive reaction video up here as soon as it's ready. Thank you for watching all the way to the end. I hope this has been useful, and I hope to see you on the next video.